Well, good morning, everyone. Thank you for joining us. I'm Dr. Laura Leacher, and welcome to today's Medical Grand Rounds. Just a few announcements and logistics before we get started with today's speaker. Take a break over the next 3 weeks to get some rest during the dark days and enjoy the holiday season. We will be again returning for Grand Rounds on Tuesday, January 6th of 2026. And we'll be hearing from Dr. Lenny Mankin, who will be giving an update in outpatient medicine. So be sure to take a break and join us back January 6th. As many of you know, Grand Rounds is a collaboration between Providence St. Vincent and Providence Portland Medical Centers. We are typically here live on Tuesdays at 8 a.m. at Providence St. Vincent, and sometimes live at noon on Tuesdays at Providence Portland. You can always join us through the Teams Live platform, and you can earn CME credit by being here live in the room, virtual live, or by watching a recording of the event. If you keep an eye on the weekly invitation, you can find links to the recording and also know for sure when and where we'll be meeting. And now to introduce today's speaker. We are joined by Dr. Miran Jose, Assistant Professor of Medicine at OHSU. She completed her medical degree at Madras Medical College in India, and then spent a year as a research trainee at the Mayo Clinic in Rochester, focusing on the genetic aspects of familial hypercholesterolemia. Dr. Jose completed her internal medicine residency at St. Peter's University Hospital in New Jersey, and then followed that with a 2-year medical genetics fellowship at the University of Washington. Since 2023, Dr. Jose has served as a faculty member in the Department of Internal Medicine at OHSU, where she's primarily engaged in outpatient clinical care, as well as the teaching of medical students and residents. We are so delighted to have her join us today to share her particular expertise in genetics with our general medicine audience. Thank you.
Thank you for the introduction, and good morning, everyone. Thanks for having me, and thanks for being here. So we'll go ahead and start. The objectives of the talk that is at the end of the presentation, I'm hoping that the audience will be able to know what's the role of medical genetics in medicine and identify adult patients who may benefit from genetic evaluation, interpret family history that's important and is suggestive of hereditary conditions, and recognize indication for genetic testing and need for referral, and also be able to interpret genetic test results for some extent and navigate the referral pathways. So to start with, I would like just to know the audience. How many of you have ever referred a patient to genetics? You can just raise your hands. Oh, great. That's great. And anyone going with option 2, 3, 4? Okay, yeah, thank you. All right. Yeah, so I came up with this talk because when I matched into fellowship for medical genetics during my residency, I had my colleagues and peers asking me, what is it? Is it research? Is it some form of bench work? And that made me realize that, okay, there is some knowledge gap, and I was interested in addressing it. And I did a study while I was in residency before graduating. And this was the result of the study among IM residents in my residency program, where I did my internal medicine residency. So 70% did know that it's about just like any other specialty, diagnosing patients and managing them. 30% of them had thoughts that it's research related or just purely genetic counseling and has other roles. And few more points that was notable from the survey that I did among the internal medicine residents was 50% of them, we had a clinical geneticist in our hospital, but 50% of them were unaware of the fact. And 17.5% wanted to order a test but didn't know how to. And almost 13% were not aware of the clinical criteria for referral, and 13% were not aware of the existence of a training in medical genetics. So we'll start with what is medical genetics. What is the role of the specialty? So just like any other specialty, they see patients. The main goal is to identify patients with disorders arising from genetic variations. That is, any genetic mutations leading to a disease condition, identifying that is the goal. So it can be inherited or it can arise de novo. So it might be running in families or can be a new mutation in one particular individual. And it can present at any age, starting from childhood to adulthood and late adulthood too. Childhood, yes, it gets diagnosed relatively easily and sooner, but adulthood, it may stay unnoticed and all of a sudden it can present with acute life-threatening conditions like aortic rupture. So for example, this is pictures of few patients with Loeys-Dietz syndrome, and they have some typical features of hypertelorism, ptosis. Yes, the two individuals on the top, the 6 and 8-year-old, they have the features, but at the bottom, it's not really prominent, but they do have some hypertelorism. Those are few features of Loeys-Dietz syndrome. But the reason we want to, or the clinically significant finding of Loeys-Dietz syndrome, the reason we want to find it is because aortic dissections is associated with Loeys-Dietz syndrome, high risk for aortic dissections. And identifying it early will help us monitor and manage before rupture happens. So that's the reason testing and detection will be helpful. And just briefly about who are the providers offering service in the specialty. So the specialty has, yes, just like any other physicians in any other specialty, there is clinical geneticists. And in addition, there is genetic counselors and non-clinical geneticists. So whenever we talk about genetics, the thought is, okay, there's genetic counseling happening. But there is clinical geneticists, they are MDs or DOs or PAs who see patients, assess their symptoms, diagnose them, and offer testing. And the genetic counselors are basically, they do masters in genetic counseling, and their role is more of pre-test counseling and post-test counseling to make patients aware what does the testing entail. So they usually work along with the geneticist. And the non-clinical folks, they are involved, they are usually PhDs, and they usually go over testing and test results and interpretation of that. Okay, and before I go more in depth, just to know the audience here again, what do you think? Is there a geneticist at Providence St. Vincent Medical Center? How many of you say yes? How many of you would say no? Oh, okay. Yes, that's correct. Okay, yes, that's correct. Yes, so we have what I understood. I contacted the geneticist, Dr. Voyen, and what I got from her is, yes, she works at Providence St. Vincent Medical Center and at Portland Medical Center, and we have Ms. Molly Davis, who is primarily at Portland Medical Center, but they are primarily involved in just cancer. If a person is already diagnosed with cancer, then they see them. This is the information I got from her, so I'm sharing it with you so that it can be helpful if for future referrals. So they see mostly patients who are diagnosed with cancer. So most likely it's the oncology team who is referring them. So less likely from primary care physicians. And non-cancer hereditary syndromes, she told they rarely see MEN1, MEN2 or polyposis, and it's consult only, no continuity of care happens. And so non-cancer genetic services is through OHSU and Legacy. And so it seems there's a breast cancer clinic where they see unaffected individuals with high cancer risk. So that's a place, if you're interested and if cases come across, you can refer them there. And for other cancer family history, no options right now, but I also heard that they're trying to hire a genetic counselor. So there might be more options in future. And just sharing genetic services at OHSU, yes, they have different services available for cancer genetics, cardiogenetics, and adult genetics, and few others. And adult genetics, it's great that we have one because it's rarely available in like specific adult genetics is rarely available in genetics department because it's majority of the patients are pediatric genetics patients. And most of the providers who go for genetics training is also pediatric trained. So they naturally navigate towards, gravitate towards pediatric patients. But sometimes they do end up seeing adult patients because we don't have providers to see adult patients. All right. And since we have so many specialties, just to give an idea of what is the common reason adult patients get referred for genetics is usually cancer genetics. cancer-related conditions. So this is a study from University of Washington, where they have an established adult medical genetics clinic. And so this is from the data they have from 1975 to 2016. You can see the most common reason for referral is cancer genetics. And it's actually followed by cardiovascular from other studies. I think they didn't take the data for cardiovascular genetics. But yes, cardiovascular is also a common indication for referral, followed by neurological conditions. All right, so before we go in deep for indications of referral, we'll start with the clinical scenario. This is a patient I had in my clinic in my primary care practice. So she's a 68-year-old female who comes in just to establish care, no concerns, no past medical history. And while reviewing the family history, she did mention that there's family history of breast cancer in her sister. And exam is unremarkable. And towards the end of the visit, she also noted that her sister is positive for BRCA1 gene. So at this point, my next question is, okay, is this something running in family, or is it just the sister who had a de novo mutation? And and also, is there anyone else in the family who is affected? And this is a pedigree that usually people in genetics department do. It's an elaborate family history. Of course, as PCPs, we don't get the time to do this. But the basic family history that we can obtain from patients during every visit, or like establishing care or annual visitors, first degree relatives, sisters, siblings, or parents who are affected. So this patient did have her mother who had ovarian cancer. So if you see, this is the patient who is the proband, and this is the sister who has BRCA1 mutation, and she had breast cancer at 39, relatively young age for having breast cancer. And mother had breast cancer at 53, again, ovarian cancer at 53, relatively young age to have ovarian cancer. So taking this into account, most likely the sister got the BRCA1 mutation from her mother because both of them have it. Now the question is, should patient worry about it? Yes, because just briefly, basics of genetics, all of us have 2 copies. Or also, this is something I would hope we can share with our patients, the basics on why we think they need referral for genetics or they need to be evaluated. All of us have 2 copies of each genes. Like BRCA1, we have 2 copies, one from each parent, mom and dad. And same with this patient, she got 1 copy from her mom. And since BRCA1 is an autosomal dominant gene, which means we just need 1 mutation for it to manifest as a disease. So most likely if her mother had 1 affected gene, then so let's say here we have father in this picture, father is the affected person, but let's say this as similar scenario as the mother who has 1 affected BRCA1 gene, there's a 50% chance mother transmits her affected gene to her children, or 50% chance that she transmits her unaffected gene to her children. And unfortunately, the sister did get the affected gene, which is the 50% chance. And our patient, she would have got there's a 50% chance she got the normal gene, and then she's fine. She doesn't have to stress about having a cancer in future. And also briefly, a little bit about de novo mutation. De novo mutation is where parents are not affected, family members are not affected. This is the new mutation in that patient. So most likely the mother had a de novo mutation that she gave to her children in the previous case. That's what we call de novo. And so in this case, in this case, since we know that, okay, sister has, mother has, what would be the next step as a recommendation for our patient? She is in the primary care clinic and she's worried that she should be worried about cancer or not. How many of you would go with 1? Option 1. Option 2? Anyone for option 3? And anyone for option 4? Great. Okay, thank you. Thank you for voting. And let's see. Yes, so option 4 is the correct answer. And so the point here is, yes, genetic testing, option 3 is also correct. Genetic testing is recommended for sister because there's a 50% chance she got it. But the information that we want to share with the patient is that since sister already underwent the genetic testing, we want and we have the result and the testing has been done. So we don't have to test the whole BRCA gene, one gene for the patient. We just need to test the particular focus where the sister tested positive. So letting the patient know that try to collect the information from your sister, try to get the genetic test result from your sister, and when she goes to the genetics clinic, she can take that. So she gets a targeted testing, which is less expensive, done, and then that gives the answer for her. And so this patient actually, so this is how a genetic test report looks like, just in case a patient shows something like this to us in the clinic. And this patient actually did turn out positive for BRCA1, just like her sister. And she started early screening. And unfortunately, they found a large lung cancer lesion when they were screening for the other cancers, which was an incidental finding, though the goal was something else. So the genetic test report usually looks like this, and this is so this will say what the gene is, and this will say what the mutation is, but we don't have to worry too much about it. It's usually the genetics team who'll care about it. If a patient shows something, what we want to see is what is written here. If it's positive, yes, we want to make sure patient gets the next step of care, meeting with geneticist or following up for the high risk screening or whatever is the management options. Then there can be other results also that can come up in that location. Instead of pathogenic or positive, it can be it can be benign or likely benign, which is negative. So it's very reassuring. Even if a patient says, oh, I have something, and it says benign or likely benign in the report, we are reassured that patient doesn't have anything. But if it says variant of uncertain significance, what it means is the test report shows some change in the gene, but we don't know what it means. Is it disease causing or is it not disease causing? We don't have enough data. We don't have enough information to come to a conclusion. And this is a test report where many providers and patients are confused, and there's a lot of misinterpretations happening. And sometimes management changes happen with this. Has happened, like surgeries, which has become a news in the past. But yeah, we do not need to make any medical changes in medical management based on variant of uncertain significance. Even if patient says, oh, I have a positive, or like if they think it's positive or if it's disease causing, still, unless a geneticist says, okay, this is concerning, this needs to be taken care of, we shouldn't change any management based on variant of uncertain significance. All right. And in this patient, how will the BRCA mutation change this patient's management? This patient is, of course, 68 years old, but if it's someone who is young, then we can start screening early, and starting at age 25 with clinical breast exam and annual breast MRI at age 25, and then mammo with MRI from 30. And also, if a male patient is identified with one of these genes, then yes, there is risk for breast cancer and also risk for prostate cancer. So again, screening starts early. So these are the few ways genetic testing can help. So can change screening options, management, then identifying other family members who are affected, and also can help with treatment for certain chemotherapy medications, depending on what type of mutations patients have and what gene is involved. And we'll go for the next clinical scenario. And this is one of the patients actually one of my colleagues had, and they reached out to me just to get an opinion. So I thought I'll share the clinical scenario. So a 47-year-old man presents for his annual physical with normal vital signs and examination. He asked whether he may be at increased risk for cancer. The reason he asked is because there is history of breast cancer in his mother in her 40s and ovarian cancer in his maternal grandmother in her 50s. His mother's genetic testing status is unknown. So anyone with option 1, no cancer risk in the patient because he doesn't have breast or ovaries? Anyone would go with that? No. Option 2, he would benefit from genetic testing and counseling. Okay. And option 3, recommend genetic testing for his mother first. Great. Okay. Yeah. Option 3 is the correct answer, because always it's best to test the affected person. Because his mother, if she tests negative, then there's no point testing the patient. So if she's ready to test, again, there will be issues of where family members doesn't want to get tested or don't want to share with family, then it's a different scenario. Patient will have to undergo testing. But if she comes back, so if this is the scenario, like if affected person is tested, if she is negative, then we don't have to test the patient. We just need to make sure he gets the high risk screening, because we don't know which gene is affecting or responsible for the family's cancer risk. But if the affected individual comes positive, that is, if his mother comes back positive for a particular gene, then yes, son is tested for the same gene. And if son also comes back positive for this particular gene, then he undergoes the high risk screening. And if he comes back negative, then he doesn't have to worry about cancer. That's the best case scenario, where mother is positive and he is negative. Where a gene is identified, affected gene is identified in his parent, and he's negative, then it's very reassured that he got the normal gene or unaffected gene from his parent. So that's also another advantage of testing, is that it gives reassurance for them that the future risk that family had might not be there in the person who is who's worrying about it. And just briefly about different types of genetic testing. So we have different testing options. Like there's so many different tests. So the one we talked about in the first clinical scenario was the targeted single variant testing. That is testing for that particular variant in the gene, which came back positive for the other family member. And then the whole gene can be tested, like testing for the whole BRCA1 gene. And variant is like a specific protein change or specific like the adenosine change. But single gene testing is more broader, and gene panel is testing for any genes associated with breast cancer, like BRCA1, 2, ATM, CHEK2. There's so many genes now they have found, so testing for all of them. And then we have whole exome sequencing, whole genome sequencing. Basically, it's testing the whole gene. So the point I want to share here is there is so many different types of testing. And if we don't know what to test for, it's easy to order the whole exome sequencing and genome sequencing, and we are not missing anything. It's a broad net, so we won't miss anything. But the fact is the cost is high and it's expensive and it's time consuming, and we might have many VUSs, like gene changes with uncertain significance, which is going to cause a lot of confusion among patients and providers with broader testing. So that's the reason we always want to narrow down to single gene testing or gene panel. And that's what clinical geneticists usually do, is bring down the panel testing, like narrow down the diagnosis so that they can focus on panel testing. All right, now let's go to one more clinical scenario. A 46-year-old male with no past medical history presents for an initial visit to establish care. He has family history of triple negative breast cancer in his mother, who was diagnosed at 44 years of age and is now deceased. He inquires whether his sister should undergo genetic testing due to mother's history of breast cancer. What is the most appropriate recommendation? This was actually a physician, and he was concerned more about his sister. He thought he doesn't need to be concerned. So option 1, the sister should undergo genetic evaluation, but the patient does not require testing at this time. Anyone going with option 1? Option 2, both the patient and his sister should undergo genetic evaluation and testing. Okay, yeah, that's fair. And genetic testing is not indicated for either the patient or his sister. I don't think anyone is going with that. And option 4, genetic testing is recommended only for the patient's daughter and his sister. Yeah, it's correct. Option 2 is correct. Both the patient and his sister, and this is the family history again. The patient, sister, and the mother who had triple negative breast cancer. And both the patient and his sister should undergo genetic evaluation and testing, because yes, BRCA1 gene is just not like these genes, they are not always associated with just one particular breast or ovarian cancer, but is also associated with other cancers, but to a lesser frequency. So we can see that there is a risk for, with BRCA1, the female breast cancer risk is 46 to 87%, and there is with BRCA2, the male breast cancer risk is 8.9%, and the prostate cancer risk is close to 15%. So that's the reason we want early testing. And so these are few examples from clinical scenarios, but we have so many Other situations, patients do come up with, oh, family member have pancreatic cancer, family member have sarcoma, what should I do? So the best place to go for is NCCN guidelines. They have really well laid out recommendations on how to go about, or what is the recommendation that we want to make for a patient. For example, if a person says, oh, my sister had pancreatic cancer, should I undergo, like, do I have the risk for cancer? Is what they usually ask. And the question is best answered by assessing, okay, do they need to undergo genetic testing or not, or do they just need to be monitored periodically? So if you're looking for pancreatic cancer, this is the NCCN guidelines. The link to go for the NCCN guidelines, we need a login information for that. It's free, so anyone can create an account and log in. And once we go into it, then basically we need to go to this particular location, detection, prevention, and risk reduction. And then if a person says they want to know about pancreatic cancer, then click on this. And then in the it's a big document, like with many pages. So they just directly take you to particular cancer pages that they have, and they have made clear recommendations on, okay, who needs to be tested and who doesn't need to be tested. So this is an example. This is like a general testing criteria that they have laid out. This is testing for any individual with a blood relative of pathogenic. That's the one which is positive. A variant in a cancer susceptibility gene. So what it says is any patient who says, oh, my sister had this particular pathogenic variant in her gene, then naturally testing is recommended for the blood relative. Let's see, individuals with in a cancer susceptibility gene. So it's the first degree relatives is for whom the testing is recommended. And also individuals meeting the criteria below, but who tested negative with previous limited testing. So Ashkenazi, and the ones below is this one, anyone with Ashkenazi Jewish ancestry. They have a very high risk for breast and ovarian cancer because of the increased prevalence of BRCA1 mutation among the community. And personal history of serous endometrial cancer, again, genetic testing is indicated. And yes, testing is also indicated for anyone with cancer to make treatment decisions, aid in systemic therapy and surgical decision making, and a pathogenic or likely pathogenic variant identified in tumor genomic testing that has clinical implications. If it's also identified, germline is like it's present. Yeah, we don't have to go that in depth, but basically, again, it's a good resource. If we do not know the answer, then we can always look it up and give answers to patients. All right, and let's see. This is a known cancer clinical scenario. Again, this is one of the patients that I saw because they were not able to make it to genetics clinic. So I saw in the primary care clinic. So this is a 47-year-old female with a history of developmental delay, bipolar disorder, type 2 diabetes mellitus, diagnosed in her 20s, renal agenesis, single kidney, and dyslipidemia, presents for a follow-up visit with her primary care physician. During the visit, the patient's mother expresses concern about the possibility of Prader-Willi syndrome and request an evaluation for the condition. What is the most appropriate next step in the evaluation of this patient? Proceed with option 1. Anyone proceed with testing for Prader-Willi syndrome? Option 2, proceed with broader testing with exome sequencing. Option 3, refer to medical genetics for Prader-Willi syndrome testing. Okay. Option 4, refer to medical genetics for exome sequencing. All right, great. Okay, yeah, so this, the reason mother is concerned is because of the Prader-Willi syndrome is a condition where they have tendency to eat a lot. It's very difficult to stop them from eating. And it's subjective on, okay, what is considered as eating a lot, but yeah, anyone with Prader-Willi syndrome, they have to log any food sources like fridge. I had a patient who ate like 100 bottles of honey in 1 week. So the mother was concerned because she had diabetes mellitus and she is in the overweight to obese category. That made mother concerned. But one of the key features of Prader-Willi syndrome is, if we go in detail about her, we'll need to go in detail about her history from childhood / birth history, is hypotonia at birth, and they will have feeding difficulty at birth. But then as they grow, that's when they start increased feeding. So she did not have hypotonia at birth or decreased. Other features were not there that would suggest, like clearly suggest Prader-Willi syndrome. Also the correct answer is refer to medical genetics for exome sequencing, because exome sequencing is a broad test, but ACMG guidelines, they have laid out the guidelines that anyone with uh, any patient with congenital anomalies, developmental delay, or intellectual disability, they do meet the criteria for exome sequencing or genome sequencing. And they made this for pediatric patients, this recommendation. But yes, our patient was a pediatric patient at some point when she did have all these symptoms of developmental delay and intellectual disability. And now she's an adult who is still undiagnosed. And so basically, she does meet the criteria for testing. And yes, and this patient was tested and she did come back positive for a deletion in one particular area of the gene that would explain her metabolic syndrome. Yeah, I didn't put the results here. And so those are a few examples of what we come across in primary care. And briefly going over, let me just make sure the time is also, yeah, okay. Briefly going over other different situations where we should think of a genetic cause. For different system wise, we'll just briefly go over. We cannot cover everything, so just a brief overview where genetic conditions is something we want to keep in mind. Anyone with left ventricular hypertrophy, that is wall thickness more than 15 mm, but without any secondary causes, especially if the patient is young and if there is family history, then think of hypertrophic cardiomyopathy, and it's fair to refer them for genetic testing, even though it doesn't really very clearly suggest, but if there's no secondary cause that can explain it and patient is young, family history, strong indication for referral. And LDL cholesterol greater than 190. If the patient is young, 190, yes, we have so many patients who has LDL cholesterol greater than 190, but there are other clinical tools that we can use, like DCC and criteria, where we add more information like family history, LDL cholesterol, and any clinical features that we have. And depending on the score, we can decide, okay, does patient needs to be referred or not? But something to keep in mind, if we see these patients, yes, there is a possibility that it might be from a genetic cause. And some patients, they may not prefer knowing the genetic cause, but if they're interested, that's something we can always offer to patients. And someone with multiple bilateral renal cyst, think of autosomal polycystic kidney disease. And also, if a person is diagnosed, then we'll need to monitor for intracranial aneurysms in those with family history. And bilateral renal cell carcinoma, think of von Hippel-Lindau, especially if patient is young, early age of diagnosis, any family history. Family history will be less likely with von Hippel. There can be people with family members also, but even if not, things to think of is early age and bilateral renal cell carcinoma, and there will be other features too. But usually we end up finding other features with monitoring, and it happens in later stages. And family screening is also indicated if a person is diagnosed. And GI conditions, recurrent pancreatitis, 2 to 3% can be hereditary. So if again, there's no secondary cause and it's at a relatively young age, multiple episodes without clear trigger, think of hereditary cause and can be referred for genetic testing. And if a person has elevated ferritin and transferrin saturation greater than or equal to 60% in males and greater than or equal to 50% in females, to keep hemochromatosis as a possible differential in mind. And again, if not explained by any other causes. And neurological conditions, if person, most of the times we have many patients present with peripheral neuropathy. And many of them don't have a reason, especially if it's at relatively young age of onset. And if it's a female, think of Fabry disease, and that might be the only presentation for females, young female with just burning in the hands and feet. Think of Fabry disease and genetic testing. It's an indication, and it's not resolving and it's staying and progressing. Then Charcot-Marie tooth, but typically onset is in adolescent and childhood, and it will be progressive. And dementia, early on, so think of, again, genetic causes are early onset Alzheimer's disease or frontotemporal dementia or CADASIL. So CADASIL, the typical patient will be like a 40-year-old male who comes with some changes in memory and would have had a couple of episodes of TIA, but will look completely fine. But all the features that will be concerning is he had these random TIAs, and they can sometimes have migraine headaches is also common, which is not explained for the age. Then think of CADASIL. And yeah, I had a patient who was in that similar age and turned out to be positive for that. And connective tissue disorders. Yes, this is also, especially Ehlers-Danlos syndrome, that's one thing that patients usually come worry about during primary care clinic visits. The common genetic mutation related ones are Marfan syndrome, Ehlers-Danlos syndrome, and Loeys-Dietz syndrome. Just briefly about how will it be significant. So usually no one presents it to primary care clinic with the typical features of Marfan syndrome or Ehlers-Danlos syndrome, but what we may see and what we might want to worry about is if a person has aortic root dilation and we do not have an explanation, relatively young age of onset, random echo finding of aortic root dilatation, or sudden aortic dissection. And then make sure we ask family history. Is there anything similar to that in any of the family members? And then we can go into details of, okay, does the patient meet any of the criteria for the condition? And then based on if they meet the criteria, there's always, for all these, there's clinical scoring criteria that's available. And then depending on that, we can see whether patient would meet the criteria for referral. And something that's similar to Marfan syndrome is Loeys-Dietz syndrome. The first slide I had few patients in the picture, they all had Loeys-Dietz syndrome. And Loeys-Dietz patients with Loeys-Dietz syndrome are prone to aortic dissections and aneurysms in various locations, in different parts of their blood vessels. And sometimes patients get diagnosed after they undergo aortic rupture, and then they undergo the genetic testing. And then they are diagnosed, okay, they have this, and then family members might end up getting tested. Other features are hypertelorism, cleft lip, bifid uvula. That's very rare, so it's difficult to make a diagnosis with this. But in primary care, if we see aortic dissections or aneurysms, something to think of, especially young age, family history. Most of the situations, cardiology, they will be on board with cardiology, and cardiology will be thinking of it and might be making referral. And we have Dr. Shalhoub at OHSU. She specifically manages these patients who have aortopathies from genetic conditions in case like repairs if it's needed and if patients needs to be referred. And Ehlers-Danlos syndrome, just briefly, a few things, because we have patients who come to the clinic who say, oh, I have EDS. The EDS that we often, or many people are concerned about, usually falls into the category of hypermobile EDS, which does not have a genetic basis. So they don't see, or geneticists usually don't prefer seeing those patients because it doesn't have a genetic explanation. But then there are many other different types of EDS which does have similar features like thin translucent skin, easy bruising, hyperstretchability of the skin, and hypermobility of the joint. And then again, the risk there, or why we want to detect them, is increased arterial fragility, especially with vascular EDS, and increased risk for rupture and dissections. And this is just hypermobile EDS versus classic EDS. There's a significant difference in the amount of, the scarring is a feature which patients sometimes show in the clinic. Oh, there's white scars, but we can see that hypermobile EDS doesn't have a genetic etiology, or at least nothing identified so far. But classic EDS, it's pretty bad and extensive, the scarring and non-healing of the skin, not healing properly. All right, and this is just the EDS spectrum. I'll just skip this. So should a non-geneticist order genetic testing? Not typically expected, but for those interested, few things to consider. Do we have the time to complete the genetic evaluation? Maybe we can get a basic family history and review medical records to some extent. And the major challenges are if a person is not trained for interpreting genetic test result, then that might be challenging, especially if variant of uncertain significance comes, then it's difficult to give an answer on what it means, and there's a high chance patient is going to worry about it. And it's important to give counseling before and after genetic testing because of what the test result means, because is the most of the times it might be like, especially when they're testing a normal patient who comes to the primary care clinic, they're normal, they don't have any disease manifestation, but they get tested and it becomes positive, then it's something that they're going to worry about long term, uh, though there would have been few more years where they wouldn't even have had the disease. So counseling before and after testing is important. And do we know about how insurance and lab billing works? So a few things to consider before genetic testing. And overall, with this, I would conclude better not to do the order testing. The expectation is to know who meets the criteria for referral, or at least educate the patients and let them know that they have this option to get tested if they are interested. And briefly about labs offering genetic testing. So there are different labs. And the questions patient usually have is it covered by insurance? So if it meets the criteria, if there is a strong indication or clear indication for testing, then yes, insurance covers it. So most of the time, people in the insurance, providers in the insurance, they review it. And if it meets the criteria, and if we can say, okay, as per guidelines, it meets the criteria, then it's supposed to be covered. At least most of the insurances does. And most of the labs, they do verify with insurance regarding insurance coverage before proceeding with the testing. So that's something patients can be made aware of, so that they're reassured that they don't end up having a surprise bill. And if a family member gets tested positive, usually they offer discounted testing for the other family members, first degree relatives, within 90 days. Usually it comes with that. So that's an option people can consider if they want. And self-payment is also an option. And this is a common thing that's out there, direct to consumer testing. We have now 23andMe, Ancestry sequencing. They say, oh, we can give you your ancestry, or you can find what's your cancer risk. So it's marketed directly to consumers without involvement of a healthcare provider, and different companies offer different tests, but not all of them are FDA approved. So FDA has approved 23andMe for testing for breast cancer risk and for certain pharmacogenetics. And interpretation of the results may vary across companies. So if someone comes up with a result, it's difficult to again assess, but it's more reassuring if it's a CLIA certified lab. Otherwise, it's not completely reliable. And other things to note with direct to consumer testing is, again, the downside is, or if a patient asks, should I get tested? This is available for me out there. Is yes, it's fun and it gives you more information. But it might come up with a new positive result, which might be adding more stress and anxiety, especially if there is no symptoms. So that's something they want to be aware of. And sometimes it might come with variant of uncertain significance, which is not a useful information, but can again add more stress and anxiety, because it may say, oh, it may be associated with certain diseases, but we don't have an answer to it. And just with regards to clinical genetics at OHSU, they don't see patients for direct to consumer test results, because most of the times what happens is they find something in the direct to consumer testing and then they want to see a geneticist, which then geneticists are not really happy about interpreting that and then making recommendations based on that. Because ultimately what will end up happening is they'll ask to have them test through a CLIA certified lab. And other considerations when placing a referral, if we place a referral, things that will be useful is making sure knowing who are the family members affected, and if we have a genetic testing results from the family members, then that's always useful for them to take to their genetics appointment. And for pregnancy planning, if patient want to know what's their risk for having a baby, though they are not pregnant, referral should be directed towards prenatal genetics. That's usually through Women's Health or OBGYN. And there is option for urgent referrals. That situations where urgent clinical genetics referral is indicated is where they want to make decisions regarding surgery. Mostly happens in case of cancer, where they're already diagnosed. So usually oncology takes care of it. And yeah. And briefly about GINA, which is Genetic Information Non-Discrimination Act. So it was passed in 2008 to protect people from information that they know through genetic testing from getting a health insurance or employment, because this is an information where we get to know without having a disease. So yeah, basically what it does is there is protection against health insurance and employment. But what we want to educate patients, if someone wants to do random testing, is we do not have protection. So it doesn't cover for life insurance or disability insurance or long-term care insurance. So that can be used by the insurers for deciding on the coverage or premiums. So something to pass on to the patients, so that if they want to take life insurance or disability insurance before testing, then at least that can help them with insurances that they want, that might not end up getting covered with high premiums in future. And let's see. And yeah, just briefly about resources we want to refer to if we have a patient and we don't know what, like they're asking what is my cancer risk or what is my genetic risk for so and so conditions. NCCN guidelines is the best resource for cancer related conditions. And gene reviews, it has peer reviewed articles about different genetic conditions. So it covers majority of the genetic conditions, like non-cancer related. So that's a great resource. And a genetic and rare disease information center, that's also great. And it's also can be given to patients. So a few sources we can use to guide our decision. And summary of indications to consider for genetic evaluation: family history, that's the key. And of course, we cannot take an elaborate one, but at least making sure we know the family history of first degree relatives. And multiple affected family members, especially if two or more affected, think of genetic cause, early onset of disease, dementia before 60 years, or type 2 diabetes before 40, stroke before 50. I know it's overall too many numbers, but what you want to think of is cancers before 50 years of age, and other stroke and dementia and coronary artery disease before 50 and 60. And diabetes, yes, with age, it's easier for a person to get diabetes, so less than 40 years of age. And hereditary cancer syndrome, if a person, breast cancer in male, think of hereditary cause, early onset, less than 50 years of any cancer, not any cancers, the breast, ovarian, endometrial, prostate, or colon, because these are the cancers we have a gene identified. But for lung cancer, we usually do not recommend genetic testing because we do not have a gene identified. So these are the common cancers we want to think of. And pancreatic cancer, also genetic testing is recommended. But other cancers, brain cancer or sarcomas, yeah, I wouldn't worry as much about genetic testing. Then bilateral cancers, like impaired organs, if both the sides are affected, then think of a genetic cause. And multiple locations being affected, and synchronous or metachronous tumors, or constellation of cancers in same patient or multiple family members. And sudden cardiac death in healthy individuals, again, think of a genetic cause. And yeah, just key points: family history is the key, and affected individual should be the first person to undergo genetic testing. So anytime patient asks, should I be tested? So always direct them that if their affected family member can get tested and give a copy of it, then that would be the first next step. And always keep in mind, variant of uncertain significance does not indicate a positive test result, and do not change management based on that. And consider genetic evaluation for unusual presentation without a secondary cause. All right, I think that's it. And these are the references and acknowledgements. And thank you. And any questions?
Many thanks, Dr. Jose. I'll open up to see if we have any specific questions here in the room.
Considering BRCA testing and the multiple genetic abnormalities, does the landscape keep changing for the ones of unknown significance? Do they move from one category to another? And if you were tested 15 years ago, should you be tested again, kind of thing?
Yes, yeah, that's a great question. Yeah. Yes, it keeps changing. And usually something that I missed to mention is anyone with variant of uncertain significance, the recommendation is please come back and see us in 2 to 3 years, and we'll revisit. did the interpretation of the gene change? Because by that time we'll have more data. So yes, it's something we keep revisiting. And sometimes if data comes up as pathogenic, patients are automatically notified that this has been changed as a disease-causing gene. So yeah, that's something to keep note of. And most of the times, like majority of the times, it gets changed to benign or likely benign. That's not disease-causing. That's the usual path of change.
Great. I'll take a question from here. So thanks for the information at the beginning about our own institution. So for many of us who don't have broadly available genetic counseling and testing within our own institution, and sometimes barriers to referral, cost and logistics, we do have access to Invitae through LabCorp. And I'm curious if you have experience and comments with regard to the genetic counseling that comes with that. It looks like the order comes from the primary care doctor, but you have the opportunity to refer to these third-party programs. Curious if you have anything more to say, if that is what's more readily available in your primary care setting.
Like in terms of what is the option for counseling?
Right. So if you as a PCP may not have the time and expertise to fully pre and post counsel on the testing, what is the experience and can we trust the genetic counseling available through third-party programs like Invitae? And not sure if you know, but it would be an interesting question.
Not to the third-party programs. I know they do the testing, but genetic counseling is usually through clinical genetic counselors, because the ones in the lab are non-clinical genetic counselors. Yes, they have genetic counselors, and they are usually more helpful in guiding providers. They're willing to sit and walk us through on what is the process involved. And that's the usual role of genetic counselors in labs. But the non-clinical, that's what I know about non-clinical. But usually we send them to clinical genetic counselors. Like most of the cancer risk programs have genetic counselors without providers. So that's an option.
Yeah, thank you. A little different landscape. I do think some of them do virtual visits with actual genetic counselors
That's
online.
great. Yeah.
And just to reemphasize, yeah, that we do have the high-risk breast cancer clinic here, which is a great resource for counseling. Good. Other questions in the room? Great. Well, thank you. And then I think we'll leave it at that. Thank you, Dr. Jose.
Thank you.